Welcome to Q&A with Prof. A. This is the Ibato kay Doc Bato educational series for medical students and residents. What are the indications for use of the different parenteral solutions? You have your isotonic solutions, which are your 0.9% normal saline, plain LR, and your D5LR and D5NR. Your dextrose-free isotonic solutions are usually for resuscitation, while your D5LR and D5NR are usually your initial fluid of choice. However, if you continue to give these fluids post-resuscitation, it will lead to hypernatremia. And it is not for patients with cardiac, renal, or hepatic failure unless in shock. While your hypotonic solutions like your D5.45, D5.3, D5NM, and D5IMB are all for rehydration. They have been historically described as the maintenance IV fluid of choice. However, FDA describes them as a follow-on fluid after boluses with isotonic solutions. Therefore, they are post-resuscitative fluids. And if given too much, will lead to iatrogenic catastrophic hyponatremia. What is now the role of ADH and hyponatremia? There are two mechanisms for hyponatremia and ADH secretion. You have your depletional or physiologic or normal appropriate antidiuresis. This is triggered by decreased effective blood volume, triggering now your renin-angiotensin-aldosterone system. With your angiotensin II, it will release a lot of ADH, such that with the increased water intake, it will lead to hyponatremia. While your dilutional, pathologic, inappropriate antidiuresis, there's exogenous secretion of ADH from brain or lung or hematologic cells, such that with increased water intake, there is hyponatremia, or what we call as true euvolemic hyponatremia. How do we now apply our knowledge of the different fluids with the mechanisms of ADH and hyponatremia? With depletional, normal appropriate antidiuresis, once the effective blood volume is corrected, renin-angiotensin-aldosterone system will be inactivated, leading to a decreased secretion of ADH. With a very low ADH, you'll be secreting a lot of water or hypotonic urine, such that a best replacement will be your hypotonic fluids post-resuscitation. While for dilutional pathologic inappropriate antidiuresis, there's a continued release of ADH. And to prevent hyponatremia is not to give hypotonic fluids, but instead give isotonic fluids. In both cases, you cannot give them at a rate of IV maintenance. Use the idea of IV maintenance fluid requirement as your ruler or norm, such that for patients with SIADH, with cardiac, renal, liver failure, or altered sensorium, you decrease your maintenance from 75 to 80% maintenance rate. On the other hand, if your patient has increased sensible from renal GI losses or from sepsis or anorexia, or increased insensible losses from tachypnea or fever, you increase your IV maintenance accordingly, such that whether your patient is on NPO, tachypnic, or with altered sensorium, there's really no room for IV maintenance fluid rate. What is the moral of the story? Before using a standard formula to compute for maintenance IV fluids, please think twice or even thrice in prescribing it. Consider enteral maintenance fluids as first line whenever possible. Ensure that the child is not having higher or lower losses than usual, such that do not start the child on maintenance IV fluids. Rather, you either add or restrict your fluids accordingly. For more high-yield topics in pediatric nephrology, don't forget to click the subscribe button.